Hope you all are enjoying this so far. We've had some great remarks. There are more great remarks to come. I'm really excited to introduce this next speaker, who is a friend and mentor to me, who I first met back in 2003 and who radically changed my career trajectory from going back to North Carolina to do rural primary care to being bitten by the policy and advocacy bug and ending up, and that's due to Veronica Gunn. When I first met Veronica, some of you may know Veronica did her chief residency at Johns Hopkins. And when you're a chief resident at Johns Hopkins, you write a book called The Harriet Lane, and it's sort of the intern Bible for pediatric interns. You carry it around in your coat pocket, the pages are worn, you refer to it for everything. Well, when I was an intern, my Harriet Lane book on the front said Veronica Gunn as the author. And so when I walk into newborn nursery on the first day, my attending is Veronica Gunn, and I was, about like I was when I met Dr. Dreisner, very nervous. And she said, "Call me Veronica." I said, "Your name is on the Harriet Lane. I can't call you Veronica." But it is with that kind of genuineness and warmth that she really embraces everybody that she works with. I know she has touched many of the folks that are here. We were sad to see her leave the department, but very excited about the opportunity that she has in Wisconsin. She is currently the Vice President for Population Health Management and Payment Innovation and the Medical Director for Community Services at the Children's Hospital and Health System of Wisconsin. In this capacity, she provides medical input to the Child Welfare, Community Services, and Public Policy team, helping the health system evaluate the needs of children in the community and identify resources to enhance the well-being of those children. The new division of Population Health Management and Payment Innovation was created to focus efforts to improve the health of children, lower the cost of care, develop new payment models, and enhance the patient and client experience. We're extremely excited to have Dr. Veronica Gunn talk with us this morning.
Well, thank you, Michael, and thank you all. I am truly honored to be back and to see so many familiar faces. And as I shared with several of you, I have been consistently and very proudly following the work that you all have been doing in the past 2 years, almost since I've left, and very proudly share this progress with colleagues in Wisconsin. So I'm starting a friendly competition, just so you know. My charge has been today to share with you a bit of an overview. Now, I know for many of you, the first part of this will be quite familiar, but to establish a level playing field so that as we enter into our breakout sessions, everybody has the same understanding and common language, we'll start with understanding the contributors to infant mortality, explaining the importance of understanding local influences on poor birth outcomes and how critical that is. And then we'll identify some community-based and clinical approaches to improving birth outcomes. And I'll use some examples from Milwaukee to share with you. This is a overview of the outline, so you will know when you can stretch, take a little nap. So here you go. Some definitions. Again, I think this is critically important, particularly for folks who are not familiar with public health approaches to improving birth outcomes, and that is understanding what we mean when we talk about infant mortality, which is the death of a live-born infant before his or her first birthday. And I'll share a good bit of information and data with you. You will work with data in your teams, and you've already seen some this morning. I want to point out that it's important, while we often talk about rates, it's also important to understand numbers, particularly in areas where there are small numbers of births. 1 or 2 deaths can demonstrate wide variation in rates. Prematurity, low birth weight, and fetal death, you will see the definitions there as well. This is for a reference for you as you hear the rest of the presentations today. Now, you heard First Lady Haslam, Dr. Dreisner, and also Dr. Liu reference the great strides that we have made in this nation in improving infant mortality. And I continue, I've used this slide for years, and I've continued to be astounded at the tremendous improvement. That this one is dated back to 1915, and looking at the infant mortality rate there in the United States is 100. And I struggle with trying to fathom that. And there are many reasons, some of which you've heard about already, many reasons that we have had the opportunity as a nation to improve this outcome, only some of which are listed here, including establishing a national birth registry. If you can quantify, you have a better understanding of how to improve. Title V, immensely important to everybody in this room. March of Dimes, improved infant incubator, and a lot of that work was done here in Middle Tennessee and, in fact, at Vanderbilt. Antibiotics, oral contraceptives, so that women can plan pregnancies because we know those outcomes are better. Medicare and Medicaid established, and again, you heard about the expansion of Medicaid to improve women's access to prenatal care. And then child safety seat introduced also in Tennessee, proudly to say, back in the 70s, which also reduced infant injury as a source of death. Okay, well, you'll see that where we end there is right around nine deaths per 1,000 live births. And this is a comparison carrying that now from 1997 to 2010, which is the most recent data that we have published for Tennessee and the nation, is that we continue to make strides in infant mortality. Nationally, we have improved significantly down to almost 6. I want to point out that that lower level is not 0. It is still 6. And in Tennessee, as you have heard, have made tremendous improvement in infant mortality rate over the past several years, and as Dr. Dreisner pointed out, particularly improvements in the past 5 years. There still remains certainly a gap. And in reference to my earlier comments about being aware of the rates and the numbers, I think it's important to note our numbers have improved as well. And this is, again, I think a particular important to highlight both the number of deaths reduced and the rate, particularly because nationally we're seeing a flattening of births. And so when you have fewer births, your rates can increase if you don't marginally improve or maximally improve deaths. And so you have seen declines in both in Tennessee due to your continued good work. But this highlights where we still have to go. Disparities exist in poor birth outcomes nationally, most certainly, and continue to exist in Tennessee. I'm very, very pleased to see the narrowing of this gap in Tennessee, although a tad bit dismayed to see a little bit of uptick in infant mortality among the white population, and we'll see if that's a blip or a trend over time. So that gives you an overview of national trends, certainly where we are in Tennessee. And this, again, will be familiar to many of you, but I want to point out that there are tools available to help us understand infant mortality and what is driving infant mortality with regard to high-level measures. And one of the breakout sessions, I believe, this morning is understanding PPOR, which is a very helpful tool. It stands for Perinatal Periods of Risk. It was developed by CityMatch in collaboration with CDC, and it categorizes infant and fetal deaths by 2 parameters based on the weight at birth and the age at death. And I'd like to point out, for example, an infant who is 2,000 grams at birth, who dies at 2 weeks of age, would be categorized in the newborn care bucket, if you will. Now, why is this relevant? Well, it's relevant because this tool gives you an opportunity to intervene. Each of these categories has corresponding areas where there is evidence that one can intervene to address outcomes specific to that particular category. So for the largest category, for example, maternal health and prematurity, those factors that can influence outcomes, excess deaths in that grouping include preconception health and addressing health behaviors. So for this group, which is the bucket, if you will, that has the greatest impact on poor birth outcomes, both in this state and in the nation? Yeah, exactly. It's the first one, maternal health and prematurity. So low birth weight prematurity contributes the greatest to poor birth outcomes, in particular infant mortality in Tennessee and in every other state in this nation. And so it gives us a great area in which to focus. When you look at the contributors and quantify them again, so you find that the leading causes of infant mortality are, as we said, disorders related to preterm birth and low birth weight, followed by congenital anomalies. And then a distant third, but an important third, are now sleep-related deaths, which are emerging as an area of focus. So that gives us an understanding at the highest level. What are our trends? Are we improving? Are we not? Are we widening or narrowing the gap in outcomes? This helps us understand what is influencing those outcomes in particular. So there are a variety of influences. Social and economic conditions, most certainly. Knowledge, information, personal choices, families and communities, societal values, access to services, utilization of services, and effectiveness of services. All of these impact maternal and infant health. And as a clinician who has spent much of the first part of her career in academic medicine, most of the conversation we focus on are those last three: access, utilization, and effectiveness of services. And as you heard Dr. Liu allude to, these are critically important. We have to maximize our opportunities here, but they are insufficient to fully address these outcomes. And McGinnis and many others' work helps us understand why that is. So McGinnis and colleagues analyzed contributors to death in the United States, looking at it from a population perspective, and found that quality health care, quality access, utilization, insurance, all those things that we have such a vibrant dialogue about on a national scale, contribute about 10 to 15%, depending on which study, to the health outcomes of a population. Other factors influence far more. So social and environmental influences account for 20%, genetics 30%, and behaviors are the greatest contributors to health outcomes. So why am I sharing this with you? I'm sharing this is because in order to improve birth outcomes, we need to understand how all of these things influence a woman's health before pregnancy, dad's health, the behaviors of mom during pregnancy, the behaviors of family members, and the environmental and cultural influences on those families and on that child in order to have a maximum impact on birth outcomes. The best way to understand that, I would argue, is understanding it locally. And so I'm going to use an example of experience in Milwaukee. There are many examples that I could share from our working together in Tennessee as well. And what I call this is understanding the why. So we understand a lot about the what from statistics, from data, but understanding what is behind those statistics, why those statistics emerge, is critically important and I think is best understood locally. So let me share with you a little bit about Milwaukee. Milwaukee is a city surprisingly not unlike Memphis. I was told this before I moved there, and I thought, you have got to be kidding me. And I was astounded at how similar population size, similar population demographics, similar opportunities and richness of culture, and similar challenges. And one of those challenges is in poor birth outcomes. When you look at infant mortality in Milwaukee as a whole, you will see that it's not moved much. There's been marginal improvement since 1999 in infant mortality rate. There has been some improvement in recent years in infant mortality among the black population, which is that red line at the top. And again, relatively steady, although again a slight increase, in fact, in infant mortality amongst the white population. Something that astounded me when I moved there is I learned that Milwaukee is the most segregated city in the United States. And we could talk for a long time about how that happened. But the fact is that it is. And that has tremendous impact on the cultural and the local influences on health as a whole, and on the city's understanding of those influences. So if you look at this map for Milwaukee, this is Milwaukee County, in which Milwaukee City is the predominant footprint. And you can see the red tinged areas represent where our African American populations reside. The bile green color is where our Latino populations are. And for comparison, Waukesha County, that's how it's pronounced, Waukesha County, directly to the west of Milwaukee County, is almost entirely Caucasian. So it really is quite remarkable. And the area in which we have the greatest concentration of poor birth outcomes is found in that circle there. It's comprised of about 6 or 7 zip codes. So in understanding the why, Milwaukee, about 20% of infant mortality is attributable to a combination of sudden infant death and sudden unexplained death. And of these, the majority died in an unsafe sleep environment. It was not the only factor, certainly, but that is a pretty impressive statistic. And the majority of those affected were urban, minority, poor families. Public health in the city of Milwaukee, doing what they could to try and address what they truly saw as an epidemic, thought that they would start with a broad campaign. We are going to educate families in this area about safe sleep. And they partnered with a local agency that had had great success in ad campaigns with many other companies in the past. Their strategy is kind of astounding people, shocking people into action. So this was the campaign, and I will read this for you. It says, "Your baby sleeping with you can be just as dangerous." And these adorable little infants are in bed with a butcher knife. Another campaign, same campaign, another ad from that says, for too many babies last year, this was their final resting place. Now, these ads are certainly compelling. They certainly get your attention, and they absolutely take your breath away and start conversation. It's important to note that these ads were prefaced by this ad campaign just a few years earlier. Same rationale. We've got to raise awareness about this in our community. And so sofas and mattresses were placed around the city with this quote on it, which says, "Imagine how many babies would still be alive if they slept in a crib." And it's an outline, of course, of an infant on these. So I've heard a couple of moans, and that I will share. We have a wonderful relationship with public health, and this was every bit of good intention. And I don't think this was the impact that they sought. This did garner tremendous attention nationally and pretty robust dialogue, but not necessarily productive dialogue. And I don't know that it helped, that it allowed us or reflected an understanding of why this was happening in these communities. So when you talk to communities, when you talk with families in these neighborhoods that are most directly affected, here are some of the things that you learn about why unsafe sleep environments occur. So one is most certainly economically driven. These are often families that have multiple families in one housing structure where there aren't many places to sleep at all. And the implication or the feeling is that sleeping with mom and dad is safer than sleeping on the floor or in other places. But other important factors are there were mixed messages about safe sleeping and what safe sleeping entailed in the community, and from very credible voices. There were community leaders that had tremendous reach and a lot of passion who felt very strongly that co-sleeping was culturally consistent and appropriate, and this was this was not an area in which public health or anybody needed to be poking their noses. And then again, there was resistance certainly to poorly informed public respondents who vilified parents. And I put just a sample of some of the reactions that happened along with this. And I don't know if you can read this. So there was a bill that was drafted that would make it a felony for adults who cause harm or death to a child if they were impaired while co-sleeping, believing, not correctly, but believing that these parents who co-sleep must be under the influence. And that long quote is from a wonderful, bright woman who's the president of and CEO of the Black Health Coalition of Wisconsin, who says, when you look at it, they just see this as something affecting them and not us. Co-sleeping crosses racial lines, but when we talk about infant mortality, babies in some poor third world countries have a better chance of reaching their first birthday than black babies in some zip codes in Milwaukee. And then the last two quotes are from active bloggers about health in Milwaukee. The first one said, basically, this is not a crisis. We are blowing this up far out of proportion. An infant actually has a greater chance of being murdered than dying from strictly co-sleeping. So we don't need to worry about this. We need to focus on something else. And then this last one, unfortunately, reflected a great deal of the misunderstanding and sentiment locally, which was these parents that drink, smoke, and sleep with their babies get what they deserve. And it is heartrending to read comments like that, which were numerous. It reflected an intolerance and an ignorance about what truly was happening, what was driving this particular behavior that resulted in an outcome. Unfortunately, now we have learned, and so there is some new messaging around safe sleep that you will see in Milwaukee. So you won't see as many of the ads with the butcher knife. You will now see far more ads recommending the ABCs of safe sleep, alone, on the back, and in a crib. And now the Milwaukee City Health Department messaging is around sharing a room, not a bed. So trying to change the conversation from it's not about culture, it is about this bed or this bedding or this sleep surface that makes it unsafe. And that, I think, is a little bit more productive of a dialogue. There also has been some community-based action, and that action is entitled LIFE, the Life Course Initiative for Healthy Families. This is a community-based dialogue that is supported by the Wisconsin Partnership Program and the University of Wisconsin, and has been convened and facilitated by now 2 different community organizations, one in the planning stage and now in the implementation stage. And it solicited wide stakeholder input. The structure that was utilized for this I thought was very interesting. They, instead of doing straight health assessments, which are very helpful tools, they made use of existing health assessments and engaged the community in dialogue, one-on-one, as well as through focus groups in each of these different areas. So in fathers, they engaged fathers intentionally and sought their input, the faith community, funders, and the public at large. And then the planning bodies were created, again, evolved over time based on great input and feedback from the community about what was relevant for this community. And this community felt very strongly that having an African American oversight reflecting the cultural experience, particularly of African Americans in these communities, would be critical. And so there is an oversight task force through which these planning items have been vetted. The community-based action continues in that each team, and there were teams across southeastern Wisconsin. Milwaukee was one of those teams. Each team developed their own plan, and so this is the planning document and implementation document for Milwaukee. And there was a wonderful kickoff this past spring after the planning and prior to the implementation phase. And these are some areas of focus that were highlighted by the community. Now, you'll find that there's a lot of similarity in what you as public health and maternal and child health professionals and caregivers would have identified. But because these came up through the community, we have more confidence that these will directly affect those determinants in the local arena. Peer or social support networks, group prenatal care models, home visitation, supporting medical homes, and getting fathers involved are all focus areas. In addition, the media has been a good partner in this effort. The local newspaper, the Milwaukee Journal-Sentinel, has run a series on empty cradles or infant mortality, raising awareness, providing education, and explaining things in ways that they're trying to reach more than just the affected population, but acknowledging that we are all affected by infant mortality. Now, as you heard Michael say, I work for a large health system, and there was a question about what is our role in this initiative. And admittedly, I have a different perspective on things than maybe a traditional health system does. But our system, I'm very proud, has been engaged in this in multiple arenas. Our clinician educators have continued to serve in the media in regards to education of the public. Our primary care providers have continued to provide preconception health promotion, teen pregnancy prevention. We have a Medicaid health plan as part of our system, and our health plan has engaged in a number of initiatives to improve birth outcomes, including prenatal care coordination, Text for Baby, your baby incentive program, and smoking cessation resources. And our health system, I want to highlight these next two, our health system as a whole and our community health unit. Our health system said, we cannot be credible advocates for safe sleep when we're not doing this in our own hospital. So when you go to hospitals and look at babies in the cribs, what do you see in the cribs with them? You see alcohol swabs and stethoscopes and thermometers. Babies historically had not been in onesies because those were hard to access and quickly get to the baby. And so we started a safe sleep campaign within our own system. And for context, we serve the entire state. Most of our clinical reach is in the southeastern part of the state. And we have about 400,000 plus reaches across that system a year. So we created safe sleep environments in the hospital. No more moms sleeping with babies in the hospital, which was not all that unusual. And thought we would go from there to creating safe sleep messages for the community. We trained all of our staff across the system, 5,000 employees, on safe sleep. And the second aspect I want to share just a little bit about is through our community engagement work. One unit within our health system is partnering with neighborhoods, and 3 neighborhoods in particular here. The Metcalf Park neighborhood, which is designated by number 1, the Amani Franklin Heights neighborhood, which is number 2, and the Lindsay Heights neighborhood, which is number 3. These 3 neighborhoods are in the hardest hit areas affected by infant mortality, as well as many other poor health outcomes for children. And we have concentrated our system resources in partnership with these communities. So for example, our system has school nurses, and we have concentrated our school nurses in schools in these communities and implemented the coordinated school health model of nursing care and coordination in the school. We are also partnering with local agencies and public health, as well as other community advocates, to create family care centers in the community centers in these communities. So it is a nurse practitioner and nurse-based model of family-based care for kids and their caregivers, because we recognize to achieve healthy kids, mom's got to be healthy, dad's got to be healthy. And so that is part of our enterprise as well. 4 represents our clinic, and we have a clinic that serves most of these families, and you can tell over time the families have moved northward and westward, but our clinic has not yet moved. So let me wrap up with highlighting some programs that we know work. There are those that have broad impact, which include having multifaceted, comprehensive, and I emphasize local efforts. We understand the what at the high state level with our data. What we don't understand is the why, and you understand that locally. Focusing on maternal health with family planning, smoking cessation, supplemental nutrition programs, partnering with WIC. Certainly maternal care, smoking cessation again, diabetes care is critical. Newborn care with regionalization, and infant health. These are all areas that we know work. What is important in order to developing a comprehensive strategy is finding out which of these is most appropriate to the community that you serve so you can prioritize resources appropriately. So key points, infant mortality really is a manifestation of a set of complex factors, and so there is no, as we have told our colleagues in the media, there is no one simple response, as much as we would all love to see that. So reduction efforts really should address those multiple factors, which you have to understand by talking and understanding those local influences, what I call the why. And engaging community members and organizations in implementing those solutions. We have all experienced efforts where we have implemented evidence-based strategies that did not achieve the outcomes that we expected because they oftentimes were not done in partnership with the group that had the greatest stake involved. And then certainly all stakeholders have a role in improving poor birth outcomes. I'll leave you with some photos from our communities and some of the groups with whom we work to improve health outcomes in this area. So thank you so much. And I want to emphasize how proud I am of everybody in this room for the work that you have continued to do year in and year out to improve health and birth outcomes for kids in this state. Thank you.